Hello, real clinicians, and welcome to another case review. I'm joined today by Dr. Brian McCormack, an endodontist in private practice at Stony Brook, New York, and also a staff endodontist at both St. Charles Hospital GPR program and the postdoc program at Stony Brook School of Dental Medicine. So, Dr. McCormack, thank you so much for joining me today.
Thanks for having me, Ali.
So I met you at this year's AAE meeting in San Francisco, and then you expressed an interest in sharing some of your clinical cases and experience with our audience. First, thank you so much for doing that. And I look forward to reviewing many cases with you in the future. So let's get into this first case that you wanted to share. This is a case of a diabetic patient with a history of pain and swelling in the maxillary right area. We've got a maxillary first and second premolar with a history of previous endodontic therapy. Both fillings appear to be pretty short of the end of the root, and there is a long span bridge present. Can you please describe to us what you see here? What is the patient's pulpal and periapical diagnosis in this case? And what are some of the treatment considerations for a patient, a diabetic patient like this, that you had to keep in mind before proceeding to provide a treatment plan?
Certainly. So first we'll start off with the radiographs and we'll talk about a little bit about the medical history. So the patient was seen for his regular checkup with a dentist when she noticed a apical swelling in the area of 4 and 5. Patient actually didn't present with real pain. He noticed something was going on that made him present to his general dentist's office. He was quickly sent over to our office where we took traditional two-dimensional radiographs and noticed the patient had a 4-unit fixed partial denture extending from 2, 3 missing, with the anterior abutments being 4 and 5. Once we took appropriate radiographs and appropriate testing, we decided to use a narrow field CBCT image of the tooth. Just like you said, we can see a short fill, so we know from the literature, short fill, we may not have gotten proper 3-dimensional cleaning and shaping that we want in order to get our irrigants to the apical terminus where we want to clean to. And also one of the shortcomings of 2-dimensional imaging is we're looking at number 4 there, and you can argue, did they find a palatal canal, or are we just looking at a single fill? So in these type of cases, I always like to have everything at our disposal, which in my office I've been using narrow field CBCT for at least 5 years now. As far as the medical history, whenever patients present with diabetes, you want to get a full history. You don't want to just know what their daily blood glucose level is. You want to know what their A1C is, and you want to know if they've had long-term control. Just like any immunocompromised patient, patients with diabetes have decreased response to certain infections. A real severe uncontrolled diabetic, you may even consider pre-medicating. It would have to be severely out of control. But patient was otherwise healthy and good control. A1C was normal from what he remembered. He kept good control of it. Had eaten breakfast that day. It was a mid-afternoon appointment. So otherwise, medically, we were okay with moving forward.
And do you, in terms of their ability to withstand stress and so on, do you try to minimize the treatment length? And then in this case, obviously, there's a question of whether you should be doing both cases or not. And we're going to talk about your treatment planning, but in terms of breaking it down into one case at a time and so on, do you have those into consideration?
Exactly, that's a good point. Yeah. So we were considering that with him, especially with his medical history. And when you see the 3D image, it was a lesion enveloping both roots. So when I treat these kind of cases, an otherwise healthy patient, asymptomatic retreatment is usually a 1-visit case. But a case like this, I did break them up into 2 separate appointments because, as we consider with other medically compromised patients, we're going to have a decreased immune response, a higher. Some literature will suggest a higher incidence of flare-up. So when I'm retreating a case like this, I'd like to do one at a time. One intracanal medication can maybe help with any bacteria to help the immune system along, as well as if we have a flare-up, at least I know where I'm at and which tooth may be causing the flare-up. So for this particular patient, I did break it up into 2 separate visits for him to make sure everything went smooth and that we got the optimal cleaning and shaping that we could expect.
Yeah, in a case like this, obviously with the lesion being completely confined to 2 of them, it becomes also a question of, is it only from the second premolar, or is it from the first premolar, or is it a combination of both? And I think you're absolutely right in this sense. You have to kind of hedge your bets. Obviously, you recommend the treatment for both of them, I would assume, correct? Is that what happened?
And then patients always want to know if they are educated in dental, well, can you just do surgery? Can I just extract it? So it's always important to sit with every patient and discuss every option because it's the only way they can have an informed consent. Even extraction should be brought up and no treatment at all. And for me, apical surgery in this case, after looking at the 3D imaging, was not indicated because we know we've got a short fill, we've got more canal to clean. And on the axial view that you have up there, you can see an untreated buccal canal. So not your ideal for surgical endodontics.
That's one of my rules of thumb too, Brian. Anytime there's a missed canal, it means that you have the entire length of the canals contaminated. And therefore, if possible, if there are no obstructions up on top, it's always best to treat the entire canal by non-surgical retreatment. Apicoectomy, I love the procedure. It's become so much easier and better as a result of technology and techniques. However, it's not indicated in those specific cases, but it works beautifully when it's indicated, when the infection is at the apex of the tooth due to some inability due to a post or some kind of a ledge, which you don't have here. So obviously, you went on to propose a retreatment. So was the patient, how did you go about it? So you have two teeth here, you have a lesion in between. Did you decide to treat both at the same time? You said that you did them one at a time.
I did them one at a time. So what I do always first is surgical. I always use a surgical operating microscope. So now we're armed with our 3D imaging, our 2D imaging. Medical history is under control. The patient's gotten his informed consent. He wants to save the teeth, which is always our first goal. So we started with number 4. Proper isolation of rubber dam. I'll use a dam seal. Totally different companies make different seals, but with a bridge, what you'll find sometimes with the rubber dam placement, you'll get a little pull on the distal of the dam, so you want to make sure you have a proper seal. So another reason I did it one at a time with the bridge, I wanted to make sure we kept the integrity of the bridge and the access as small as possible. So small access after proper sealing. Gutta-percha fill was in the palatal just as we expected after the cone beam, which is the beauty of cone beam. You go in there and you know what to. You still got to do the work, but you know what to expect going in. Yeah. Troughing with ultrasonics, again under surgical operating microscope, is key. Any retreatment, if you want to keep a prosthetic like this intact, I think operating microscope and ultrasonics are the key. So the canals were found, the palatal was retreated. The axis might have been 2-3 millimeters wide. And then again, because of the medical history, the patient was, we packed with calcium hydroxide, which due to its high pH will kill any bacteria that maybe we missed with our cleaning and shaping. Because there's lots of literature that shows we're going to probably hit about 66% of the canal with shaping. And then the additional is the chemomechanical irrigation that's going to help us clean that canal. So just with the history, we pushed it a little further with calcium hydroxide and split it up. The patient was, and again, you want the patient on your side. The patient was okay with multi-visits, and I was more comfortable doing it in this case.
Yeah, and I think here, given the medical history also, diabetics have also a little bit of a delayed healing, so anything you can do to help, it would be obviously appreciated. So you proceeded to do the second premolar, and that was fairly straightforward by removing the gutta-percha and then finding the additional canal. But then the more challenging one was apparently the first premolar that you proceeded to go ahead and retreat at a subsequent visit. And inside there, as you can see from the x-ray, there's some strange looking things going on in there, and these are the things that you actually retrieved, right? Can you tell us a little bit more about these contraptions?
So I don't know the exact dates, but at some time when obturators became popular, the first generation of them was gutta-percha wrapped around a file, which to me is interesting because you spend your whole treatment appointment trying to avoid separating file, and then in the end we're operating with files. So these are the old thermophils. The thermophils had a bunch of changes, but this was the original. And what it was gutta-percha wrapped around a stainless steel file. So that becomes challenging. Again, going in and with the cone beam, we could tell based on the beam hardening that we were going to have some kind of metallic object in there with some certainty. I mean, not always perfect, but we knew there was something metallic in there.
Brian, what are your tricks for removing these types of metal obturators that there are clearly challenging?
See, if you're looking at the one at the right of the screen, it's just like post removal to me. I think of it as post removal and making space. So you'll notice the top of the carrier is missing all the gutta-percha, and that's not by accident. What I'll normally do is go in with C-form. Again, they make special rubber dams that'll keep C-form from melting the rubber dam. You want to always make sure you have a nice seal. If you're using C-form and you're not using those rubber dams, you may be melting those rubber dams, so make sure you're not getting irritant in the patient or you've contaminated your field. So the coronal portion, I always take a working length and I estimate where I want to be. And for any carrier-based obturation, whether it be metal or plastic or otherwise, you want to get about 2/3 down the length of that obturator in order to get the obturator loose and sealed. So I'll use C-form and really small hand files to peck around and work my way around those carriers. And that's what you'll see on that one there. It's almost devoid, stripped of all the gutta percha, where you can see apically there's still some gutta percha there. So once you do that, and again, you can see there's some missing everywhere else, but once you get some space, because again, these were the way the clinician cut the shape was to fit a cone. The obturators are smaller than the cone because they have gutta percha wrapped around them. So now we've got access to it again with a scope and ultrasonics. And what then I'll use is headstroms, whether they be braided, and for those who don't know what braiding is, we can use one on either side, turn together, and almost like a wine cork taking out. I tend to use headstroms one at a time. I tend not to braid, and that tends to work better with the plastic obturators. The metal obturators, once I get the space I needed, I tend to use a different ultrasonic on a low power, and I back it out almost like I would a separated file or a post. So I'm working on the vibration of the ultrasonic to help me aid in loosening that once I've loosened the gutta percha on the walls. And that works pretty nice for separated instruments or ledges or blocks in the canal that you might need to get in order to get to the apical terminus.
Yeah, I agree. And, luckily a lot of times removing badly done thermophils or older thermophils and so on is not that hard. It's because oftentimes the gutta percha is pulled away from the walls and you have a lot of space you can work around it. There's also infection going on, so that's going to act itself as a little bit of a break in the seal. So those could be removed. The challenge oftentimes, these end up being able to be removed a little bit easier than the ones that are the well-done ones that don't really need to be redone, I guess. But I guess you don't need to redo those much anyway. So, all right, so let's move on to the next slide here. It looks like you did manage to remove the both obturators very nicely, and you gain length. I just want to bring attention to the tooth behind it, the second premolar that you already treated and nicely found that additional canal in there. And treated it. That kind of shows that very nicely. And here at higher magnification, it shows very nice length management, and you got your working length in there as well. And as I mentioned, found the additional canal. Brian, do you have any specific irrigation protocols for your retreatment cases that may differ from your regular cases, or do you treat everything the same?
I tend to treat most the same. With the literature, some of my approaches to retreatments have changed with some of the bacteria that we find in retreatments not really being, calcium hydroxide not being effective against them. So sometimes in the recent future, I've led more towards sometimes single visit retreatments. But I guess the main difference would be at this time, this was about 4 years ago, I was treating with calcium hydroxide consistently with retreatments. I was activating my irrigants, and there's been different phases of irrigant activation, and I recently purchased a new product that I use to activate irrigants. But at that time, I was using a U-file, or it might have been a piezo. But I would tend to do the traditional endodontic irrigation. It was full strength sodium hypochlorite throughout the procedure. Again, assuming we have a nice seal with the rubber dam and the crown margin. That's the other thing. You make sure the crown margins are sealed and you're getting no leakage. If you're going to do 2 visits, you want to make sure there's no leakage inter-appointment, because then you've kind of ruined the whole purpose of 2 visits.
And sometimes, Brian, if you have to do cases in 2 visits, not necessarily for disinfection, just because you don't have the time, or the patient doesn't have the time, or the schedule just doesn't work out to be done in a single visit, that's another important reason why you should have a dressing in the canal, because during the time period in which you're waiting, that bacteria will surely grow in the canal that's not obturated, and that's why it's important to have some kind of antibacterial dressing. In those cases, do you always just recommend calcium hydroxide, or do you use any other medication?
I tend to always be using calcium hydroxide at this point.
Yeah. I think it's the most innocuous material, most biologic. We used to use a lot of different harsh chemicals in dentistry and in endodontics, and I think that area really has come to an end. With calcium hydroxide, basically just being a soap, seems to be the least controversial type of material for use in these types of cases. What do you
I agree, and it's an easy thing to explain to patients too, because everyone, if you're a doctor and you're treating the case and you tell the patient I'm putting a medication in the tooth, most patients are concerned. They want to know what medication you're putting in my tooth, and if you're whatever you're placing, you should know what you're placing and how it's working. So people get worried right away. Oh, I'm allergic to this. I'm allergic to that. What did you put in the tooth? So I always tell people it's more of an inert material that works. It works through pH. So I explain a little chemistry to them. Bacteria don't like high pHs. The calcium hydroxide gives us a high pH. And I tell the patient, whatever we didn't just get with that appointment, cleaning and shaping, the pH of this material, which again is somewhat biology inert, it's not going to bother you. Again, you don't want to express it out because it can cause some discomfort to the patient. But the pH is what's really killing the bacteria, and patients tend to like that a lot. You let them know what you're using, how you're using it, and you're giving them the relevance of why you're using it.
I agree with you. Yeah, so I guess the moral of the story is that if you're going to use anything, always use calcium hydroxide. But nowadays it seems that more of a movement is into single visit treatments. But that also requires a specific thing that we're going to talk about as soon as I show the final X-ray here, which is this one, which now you've also obturated the case. And I think that really demonstrates the point I was trying to say, is that you've done a great job with the shaping of this canal. You have large apical diameters, which means that you've mechanically removed any potential biofilm in the area. And that is only the situation in which you could do a single visit, is by adequately addressing the potential biofilm that is present on the canal walls, getting to a large enough apical diameter. And you have also done in my opinion, the right thing of not really removing apical dentin at the expense of coronal dentin by employing files of greater taper. That every time you increase the size apically, you're also increasing the taper unnecessarily. So I think that you have very good taper here that's great for irrigation and adequate for irrigation, but also allows you to have fairly large apical diameter. So you have great shape, done a great job with the obturation, which is the reason why here is the immediate post-op. And this is the case 14 months later, and you have excellent healing here. All that area of bony lesion that was present at the apex between these two teeth has completely disappeared. By the way, what was the plan here for the restoration post-op for this patient? Was the access just going to be filled? How old is the bridge, and what is your cutoff line here to replace the bridge or not?
Yeah, the access was when I finished 4 that day. The access, and again, with a good relationship with the referring dentist, I always call and find out what the treatment plan is for the patient before we proceed with anything definitive. The number 4, the access was so minimal. When I finished the case, I just placed the bonded composite, typical etch, base, and bond, and I polished the restoration myself. I believe 5 we had done Gerristore and referred back to the general dentist. And the ultimate plan was I would have liked to get the Gerristore a little deeper in the case, but it was working well, and I had about 4 or 5 millimeters of filled resin above that. So the bridge wasn't planned to be replaced. The margins were intact. So at that point, just 2 bonded restorations, and the patient, from a financial aspect, was very happy with that. He kept his bridge. And as I mentioned earlier, I think we're on a 4-year recall with this patient already. So he was happy with the result.
So that's worked out very nicely. Also, at the 14-month, you went on ahead and took a CBCT also of the area. And that shows that you have complete regeneration of the bone in that area. And here it is. I just wanted to show this the final kind of image showing the CBCT from before and after. Really consolidating here the point of complete debridement of the root canal to get proper healing. The original root canal left a lot of root canal space that was untreated, and lots of bacteria remaining, which kind of caused the persistence of this apical disease without it being fully eradicated. And it wasn't really until you went back in there and performed proper root canal therapy that we began to see proper healing, and the evidence of that being the regeneration of the bone that doesn't happen unless there is an absence of bacteria. So, I think in a sense, Brian, these kind of cases that show also when people say, well, root canals don't work, it's true that they may not work, but proper root canals work. It's just that it's an important thing to get proper understand the proper concepts of doing root canal therapy correctly so that you can implement them, understanding the various mechanical and physical challenges that are present in a given tooth, and that's basically what we call skill, and being able to implement that so that you can begin to get good healing by getting rid of the biofilm, which is the primary reason why these things persist. I mean, biofilm is the thing that we're trying to get rid of at all time, and is the cause of our demise in these cases. And it's not necessarily as easy. So, understanding the importance of proper shaping, creating shapes that allow irrigation and allow the proper disinfection of the apical area, apical third of the root, which is the most important part, is really the main principle here for proper healing. Brian, do you have any final words here you want to add for this case?
I was going to agree with you on the shape. When you're looking at cases like this, I tend to always keep an 0.4 taper. You don't pick up the curvature as well when you're looking at a two-dimensional image, but once you get delicate hand files down there, you can pick up where you have curves, and this tooth presented with a little S curve, number 5 specifically. When you start increasing your taper, the research is going to show you're going to have an increased possible zipping or transportation of your portal of exit. And once you start doing that, you've kind of opened up an area where you may not adequately seal and you may not get good disinfection. So it was a good point you made. I like to keep an 0.4 taper when I can, and that's almost all my cases. Yeah. And if you do it correctly with the crown down or with proper irrigation and making sure you recapitulate and get your patency, you're going to get the irrigant where it needs to go. And again, to your point of apical surgery, had this not healed, which 10% of these cases won't heal, even with the greatest clinician or the greatest treatment, just due to true cysts, and the literature shows some of them are going to be true cysts, pocket cysts, base cysts, meaning they're not actually attached in the root, so they're separate entities from the root. So if we were to take, the other reason I take the cone beam is to make sure I'm not seeing unreal healing on my two-dimensional imaging. So if we were to see the healing wasn't complete in the medullary bone, because you're not going to see it on a 2D image unless it's broken through the cortical plate. And if we saw that, I would recommend that time to the patient that we have a non-healing lesion and we should go in there and treat it surgically, which is, again, they may not present with pain, but if you're following it, it's not healing at that point, you may want to consider that treatment, because it may be a true cyst that we're not getting at with traditional root canal treatment.
No, that's absolutely true. I mean, even the best skills are no guarantee that you're going to get complete healing, as some of these, at least as we said, 10% of these lesions are independent entities. But redoing the root canal completely will still give you a best chance of getting away with it 90% of the time. And in the 10% of the time where you still have to do the surgery, that'll dramatically increase the success rate of the surgery by having already done the proper job of disinfection inside the root. So it's really no loss to do the non-surgical retreatment and gain the ground in this particular case that was of the root canal space that wasn't properly cleaned out to begin with. And I guess in this case, you did a great job and you didn't even need to have that healing. And, I'm going back to the issue of taper. All my cases are, my final finishing shape is a constant 0.4 taper. But in cases where I feel like I don't have the ability to go much larger coronally, but I do want to have a larger apical diameter, I may oftentimes add a few 0.2 taper files at larger type of apical diameter. That would then allow me to kind of make sure that I have just cord right at the apex, a larger diameter. Previously, we used to do these things with the light speed system, but now you can just use 0.2 taper files, such as I use the race files in those cases because they're efficient. And I may finish with like a 2504, but then in a difficult anatomy, but then I may want to go to a larger size, so I may use a 30 or 3502 to just clean the apex to a little bit of a wider diameter without unnecessarily removing coronal dentin where I don't need to. That doesn't help me increase the success rate.
The crux of the tooth is the coronal portion, so whenever you can conserve coronal dentin, you do it to decrease fracture, increase fracture resistance.
Yeah, I mean, with the concentration of force is mostly right at the cervical area, especially in posterior teeth. So anytime you can save that tooth structure, you're going to help yourself quite a bit. And I think in that sense, some of the bonded obturation techniques that we use are also very helpful. So it was really a great pleasure to have you, Brian, Dr. Brian McCormack, in private practice at Stony Brook, New York. Also a staff endodontist at both St. Charles Hospital GPR program, as well as the Stony Brook School of Dental Medicine postdoc endo program. Again, thank you so much for your experience and sharing it with us. And I look forward to having you back very soon in the near future to do some more cases with us.
Thank you very much. Hope it was helpful.
It definitely was. I think it was great. So for Reweld Endo, I'm Ali Nasseh, and I hope you found this information helpful.